Good evening, good morning, good afternoon. Welcome to the World Health Organization press briefing on COVID-19. We have with us, as always, the WHO Director General, Dr. Tedros. We have Dr. Mike Ryan, Executive Director of our Emergencies Program, and Dr. Maria Van Kerkhove, Technical Lead for COVID-19. Dr. Tedros will first give you an update. Then, when Dr. Tedros has finished his opening remarks, we will hear a message about the Solidarity Trail. After that, I will open the meeting to questions. If you have connected via Zoom, please use the raise your hand icon to get in the queue to ask your question. If you've connected by phone, please hit *9 on your keypad to indicate you want to ask a question. I will apologize now to those who miss out, as we've got hundreds of people connecting already and asking questions, for which we thank you all. So we need to keep this briefing to under an hour so that our speakers, who are all leading this response, can get back to all the other pressing jobs on their endless to-do lists. And right now there's a lot to do. And to hear more about where we are and what we are doing and what we need to do, I will now hand over to Dr. Tedros.
Thank you, Margaret. Good morning, good afternoon, good evening, wherever you are. There are now more than 500,000 confirmed cases of COVID-19 and more than 20,000 deaths. These are tragic numbers, but let's also remember that around the world, more than 100,000 people have recovered. Yesterday, I had the honor of addressing an extraordinary meeting of leaders from the G20 countries. My message was threefold. We must fight, unite, and ignite. Fight to stop the virus with every resource at our disposal. Unite to confront the pandemic together. We are one humanity with one common enemy. No country can fight alone. We can only fight together. And ignite the industrial might and innovation of the G20 to produce and distribute the tools needed to save lives. We must also make a promise to future generations, saying, never again. Viral outbreaks are a fact of life. How much damage they do is something we can influence. I thank the G20 countries for their commitment to fight the pandemic, safeguard the global economy, address international trade disruptions, and enhance global cooperation. This is especially important for countries who are not part of the G20, but will be affected by decisions made by G20 countries. Earlier today, we held a briefing with around 50 ministers of health from around the world, at which China, Japan, the Republic of Korea, and Singapore shared their experiences and the lessons they have learned. Several common themes emerged about what has worked. The need for early detection and isolation of confirmed cases, identification, follow-up and quarantine of contacts, the need to optimize care, and the need to communicate, to build trust and engage communities in the fight. Countries also expressed several common challenges. The chronic global shortage of personal protective equipment is now one of the most urgent threats to our collective ability to save lives. WHO has shipped almost 2 million individual items of protective gear to 74 countries that need it most, and we're preparing to send a similar amount to a further 60 countries. But much more is needed. This problem can only be solved with international cooperation and international solidarity. When health workers are at risk, we're all at risk. Health workers in low and middle-income countries deserve the same protection as those in the wealthiest countries. To support our call on all countries to conduct aggressive case finding and testing, we're also working urgently to massively increase the production and capacity for testing around the world. One of the most important areas of international cooperation is research and development. A vaccine is still at least 12 to 18 months away. In the meantime, we recognize that there is an urgent need for therapeutics to treat patients and save lives. Today, we're delighted to announce that today in Norway and Spain, the first patients will shortly be enrolled in the Solidarity trial, which will compare the safety and effectiveness of 4 different drugs or drug combinations against COVID-19. This is a historic trial which will dramatically cut the time needed to generate robust evidence about what drugs work. More than 45 countries are contributing to the trial, and more have expressed interest. The more countries who join the trial, the faster we will have the results. In the meantime, we call on all individuals and countries to refrain from using therapeutics that have not been demonstrated to be effective in the treatment of COVID-19. The history of medicine is strewn with examples of drugs that worked on paper or in a test tube, but didn't work in humans or were actually harmful. During the most recent Ebola epidemic, for example, some medicines that were thought to be effective were found not to be as effective as other medicines when they were compared during a clinical trial. We must follow the evidence. There are no shortcuts. We also need to ensure that using unproven drugs does not create a shortage of those medicines to treat diseases for which they have proven effective. As the pandemic evolves and more countries are affected, we're learning more and more lessons about what works and what doesn't. WHO is continuing to support all countries in the response. We have published more than 40 guidance documents on our website, providing detailed evidence-based recommendations for governments, hospitals, health workers, members of the public, and more. More than 1 million health workers have been trained through our courses on openwho.org. We will continue to train more. We're also delighted to report that the COVID-19 Solidarity Fund has now received donations of more than $108 million in just 2 weeks from 203,000 individuals and organizations. Thank you to each and every one of you. The English version of our WhatsApp Health Alert now has more than 12 million users globally, and the Arabic, French, and Spanish versions were launched today. More languages will be added, including Bangla, Chinese, Hindi, Kurdish, Portuguese, Russian, Somali, Urdu, Swahili, and more. I have said before that crises like this bring out the best and worst in humanity. We have recently seen an increase in scams, cyber attacks, and impressions using WHO, my name, and COVID-19. I'm very grateful to those working in various national organizations providing critical cybersecurity intelligence to the WHO cybersecurity team. Thank you for your efforts to work with us to protect the health systems, health workers, and members of the general public who rely on our information systems and digital tools. Special thanks to Microsoft for assisting on this. I would like to end with something Singapore's Minister of Health, Gan Kim Yong, said during today's briefing. We're only at the beginning of this fight. We need to stay calm, stay united, and work together. I will repeat, we need to stay calm, stay united, and work together. I thank you.
Thank you very much, Dr. Tedros. And as Dr. Tedros mentioned, we've got some exciting news about Solidarity clinical trial from Norway. And we'll hear a lot more about it via a video intervention by Norway's Minister of Health and Care Services.
Dear Dr. Tedros, dear colleagues, dear friends, dear all, I'm honored to address you in this afternoon's press conference. We are in the middle of a global health emergency, but we are also in the middle of a global quest for knowledge unlike anything we have ever seen. I find this happening in the midst of all the bad news from around the world. If we find treatments that are safe and effective, we can save lives, and we can protect healthcare professionals and other high-risk groups from developing disease. It is important that all countries pull together, share data and knowledge. The Solidarity Trial is an important piece in the global research effort. Together, researchers from all over the world will assess 4 of the most promising treatments for COVID-19. This Solidarity Trial starts including patients today, and I'm very happy to be able to announce that the first patient included is a patient at Oslo University Hospital. I would like to commend the WHO in taking on the global leadership in this difficult situation for all our countries, and its initiative in setting up the Solidarity Trial. I would also like to thank John Løttingen, Executive Director of the Norwegian Research Council, for taking the responsibility of chairing the Executive Committee of the trial. Dr. Løttingen will bring expertise and experience from the Ebola vaccine trials in West Africa in 2015. This trial is in good hands under his leadership. I wish us all good luck with the Solidarity Trial. Thank you.
So following that message now, we can open the floor to questions. Before we start, I'd like to give you a reminder, if you've connected via Zoom, please use the raise your hand icon to get in the queue to ask your question. If you've connected the phone, please hit *9 on your keypad to indicate you want to ask a question. Please keep your question short and confine it to only one question per journalist. Please. I will start with Kai Kuscherschmidt from Science. Kai, are you on the line?
We talked about this a couple of times, and I wanted to ask whether there's any new data on the serology. I mean, we're still trying to nail down the denominator. There's a lot of questions about how many people are asymptomatic. Can you say anything about, the newest data that you have? Is there any serology data from China?
So I'll start with that. So yes, Kai, this is something that's very important to us and to the rest of the world to really understand what the results will be from these serologic studies that are currently underway. What we can say is that there are more than a dozen countries who are conducting epidemiologic studies that involve serology. These countries are focusing on what we call the FFX protocol, which is looking at cases and controls. It involves molecular testing and it involves serologic testing. We're working with these countries to evaluate which assays they're actually using. And it will be a combination of screening assay of or ELISA, as well as confirmatory testing involving microneutralization. In addition to that, there are a number of countries that are conducting these age-stratified general population serosurveys. WHO has a protocol that we've put out online, which is a core protocol, which we want countries to use so that we can compare results across these countries. At present, there's at least 4 studies that we're aware of that are ongoing in different countries, which involve the collection or the use of specimens that have already been collected. So these may be clinical specimens for people who have been hospitalized for other reasons. We don't have results yet. We are eagerly anticipating these results so that we can better understand what is the seroprevalence or what are the antibody levels amongst people at different age groups in different parts of the world. This is critical for us to really understand what level of circulation this virus may have or may have had in people that may have had a subclinical infection, so infection that have had mild disease, maybe they didn't seek care or they weren't picked up through the current surveillance systems. But these are ongoing. In addition to that, we know that there are a number of serologic assays that have been developed. We're working with a number of countries right now to look at an evaluation of these to see how well they perform. And that needs to be done with well-characterized samples. We have really great partnerships across the globe to be able to do this. We're trying to accelerate this as quickly as we can. As soon as we have these results, we will share them. But they're really critical for our planning purposes going forward.
And if I might add that a number of these seroepidemiologic studies are grouped around a Solidarity 2 platform. So in effect, the organisation and our partners have prioritised different research strands. Obviously, establishing which therapeutics were effective has been a major priority. But in addition to many of the studies that are going on across the world, there is now a wide group of researchers who come together, as Maria has said, to implement a common protocol, which will be known as Solidarity 2. Solidarity 3 will look at chemoprophylaxis and other interventions in health workers. We are trying to align all of our work, not to bring together as many partners as possible. That is not to say that other large trials and other efforts around the world are not important. They are. But for some of the answers that are complex, we're going to need to pool data. We're going to need to collect data in a consistent and collaborative way. Seroepidemiologic data, clinical data, data on protection of prophylaxis. These are answers we need, and we need the right answers to drive policy.
Thank you, Dr. Ryan. So the next questions are from Jeremy, RFI. Jeremy, are you there?
I'm here. Can you hear me?
Very well. Please go ahead.
Thank you so much for taking the questions. It seems that far younger people are being hospitalized in the US and in Europe than in China. I was wondering, how do you explain the discrepancy? And do you have concerns that the data that you got in the first place from China might not be as reliable as you thought? Thank you.
So this virus, this COVID-19 virus, is capable of causing infection and severe disease in people of all ages. What we know from data across a number of countries, including data from China, including data from the US and Italy and Iran and Korea and Japan and others, is that this virus can cause mild disease, can cause moderate disease, which is described as people who still have pneumonia but don't need oxygen support, who can cause severe disease, can cause critical disease, and who can kill some people. Amongst children, the data that we've seen from a number of countries is that the majority of children that are infected are experiencing mild disease, but we do have reports, and there are some publications now that describe severe disease in children. We have reports of deaths in children. There's one in China, and I believe one in the United States as well. We do need more well-characterized descriptions of severity across the age groups so that we can better summarize what we know about this in the different age groups. Ideally, what we would like to see is the use of a clinical characterization protocol. This is another data capture platform that WHO has launched, which involves systematic data collection in terms of signs and symptoms, in terms of regular sampling of hospitalized patients so that we can better characterize the natural history of this disease in people who are in hospital. But there is data that's coming out from a number of countries, and we welcome the rigorous data collection that is occurring in very difficult situations in hospitals, whether this is clinical data or epidemiologic data across a number of countries.
Maybe we could just add that we've been reporting for quite a while now on the spectrum of disease. There's no question that the elderly and those with underlying conditions have been affected much more than their age groups. But we've certainly spoken here before about the age profile of patients, the fact that in Korea, 20% of the deaths were people under 60 years of age. In Italy, the fact that up to 15% of people in intensive care were under 50 years of age. I think we'll find in Germany and other countries up to 10 to 15% of people with disease, people under 50 who have disease, will have a moderate or severe infection. So they may not progress into critical condition, but 10 to 15% of people under 50 will have a moderate to severe infection. So this is not for most people is a very mild infection, most young people. But for a significant minority of people between the age of 20 and 60, this is a significant infection. And if you listen to people who are interviewed on the media, the one thing I've seen again and again and again from people, adults who've got this, and young adults, and they keep looking at the camera and saying, this is a flu. And I think what's really emerging is a perception that this disease, while not fatal and not causing critical disease in a younger age group, is causing a severe illness in many people.
I just want to add the point that we've made a few times is that young people are not invincible. The DG has said in his speech. And it's not just a disease that this virus will cause in people. Every infection of COVID-19 presents an opportunity for onward transmission. So even in younger populations, if you do have mild disease, and you think it's no deal, what the big deal is that you may transmit to somebody else who may be part of that vulnerable population, who may advance to severe disease, and who may die. So every single person has a role to play in this outbreak in preventing themselves from getting infected. And we've listed a number of ways in which you can do that, which involve hand hygiene and respiratory etiquette, physical distancing, adhering to recommendations of the national governments. By following those rules, by adhering to that, you are preventing yourself from getting infected, and you're preventing the opportunity for onward transmission to someone who may be more vulnerable.
Thank Dr. Van Kerkhove. I now have Shoko from NHK. Shoko, are you on the line?
Yes. Can you hear me?
Yes, very well. Please go ahead.
Yes, thank you very much for taking my question, Margaret. Regarding the way of counting confirmed cases, the Chinese authorities said last month that they don't count confirmed cases who don't have symptoms as confirmed cases, but apparently there is a huge number of such